So we may suspect a fat emboli if we have a fracture of a large bone, like a femur or pelvic fracture, for example. Um, this is when fat escapes from the bone and gets into the bloodstream, and it can get stuck in the lungs, causing a PE. So we diagnose it based on the symptoms. We may see a petechial rash, which looks like a splattering of blood just right on the surface of the skin, and you might see that on the chest and the neck area. They may have some trouble breathing, some change in mental status, tachycardia, maybe a mild fever, not a high fever. Usually, they may have some vision changes, jaundice, renal failure, thrombocytopenia, anemia. They may have a high sedimentation rate, which indicates inflammation, and they may have fat in the blood. So we're going to be putting this person on oxygen. They're going to be on bed rest. We may give them some steroids to decrease that inflammation. We may give them mechanical ventilation if it gets serious enough and they just can't breathe. We may have to intubate them and put them on a ventilator. They may need pain and anxiety medication because this is a scary event. Sometimes they just have that feeling of impending doom, like they're going to die, and sometimes that could be the case, so it's not unfounded. The complications would be impaired organ perfusion if they just can't get enough oxygen, and eventually maybe death if it's something that we can't control. So infection is another complication, which we've kind of talked about already. These are the signs of infection, which you should know by now. We've said it so many times. If we do suspect an infection, we may get a culture. We may get a culture of the wound site or of the blood if we think it may be, if they may have sepsis. We may give them antibiotics, especially those large bones. We definitely don't want them to get infected. So that might be peripheral, it may be oral. Sometimes we even put antibiotic spacers inside of the bone itself if that's needed. We need a good hygiene to the site. Make sure it's clean and dry. Monitor for those signs of infection. We need to make sure if there is an infection, we may have to debride the site and drain it. We may have to give them analgesics. So those are things like acetaminophen, ibuprofen, ketorolac, naproxen. Those are common ones that we may give. Antipyretics for fever, like acetaminophen. And then if we can't control the infection, we may have to amputate. Especially if they've got those underlying conditions like diabetes, where it's just really hard for us to heal that area. So complications would include cellulitis, osteomyelitis, that gangrene, and then hopefully not amputation. So arthroplasty means a joint replacement. So we may remove the cartilage in the area that's diseased. So you can see here cartilage starts wearing down. You start having bone rubbing on bone, and then you get these little bone spurs. Those are very painful and they limit movement. So our goal with a joint replacement is to reduce pain and to restore function. A lot of times we won't do this unless somebody's, a little older, because these joint replacements can only last 10 to 15 years. So I wouldn't necessarily want to do it with somebody who's 50, and then they would possibly require another joint replacement later on in life because maybe we won't be able to do another joint replacement. You can't just keep taking bone out and replacing it with prosthetics. So this is a last resort. Before we do that, we might try to just do pain management and physical therapy. They may take NSAIDs or, even cortisone shots in that area to try to keep them active and mobile as long as possible before we do this type of surgery. Herniated discs are very common. Probably some of you already have herniated discs. This occurs when this little bulb of fluid in between your vertebrae becomes compressed. That could be from an injury. Oftentimes healthcare workers have these because we're always moving bulky things around or people around, and maybe we don't have good body mechanics. So these discs become compressed and the fluid inside leaks out and really irritates the nerve endings in this area, and that's where the pain comes from. So some risk factors would include pregnancy, degenerative orders like degenerative disc disease, degenerative joint disease, poor posture, scoliosis. I would also include, occupational hazards. And then age. So the age here is not the elderly, it's middle age. So ages 30 to 60 are our population at risk. And that is because as you age, these little water balloon things start to dry up. And if they're dried up, they're not going to herniate. So rather than having a bulging disc or a herniated disc, you would just have bone on bone rubbing together, which creates a different type of pain and immobility. But for the ages of 30 to 60, these still are filled with fluid, they bulge, and they become very painful. So pain is the number one complaint. Usually it's in the lower back, although it can be in the neck. And sometimes it can radiate down the legs. The person may complain of numbness and tingling, muscle weakness, some sciatica, which kind of feels like an electric shock going down the leg. They may have a forward tilt to their trunk to try to relieve some of the pressure. And you'll see changes in mobility. And really, when you go for a diagnosis, that's one of the first things they do is they do those mobility tests where they have you lean forward, side to side, see how mobile that back is and when the pain occurs. May also do a CT scan or an MRI. We may do a myelogram, which is where they inject dye into the cerebrospinal fluid and then take a look through an X-ray. An electromyelogram is looking at the electrical activity in the muscles or in that area. Some blood tests may include a CBC just to see if there's any infection going on, or maybe a C-reactive protein or a sedimentation rate, which is ESR, to see if there's inflammation. And then they may do something called an HLA-B27, which checks for ankylosing spondylitis, or maybe an autoimmune disorder like arthritis, to see if that's the cause. So treatment could include a laminectomy or discectomy, where we're removing the lamina or the disc. We may even put an artificial disc in. May do a spinal fusion, we're just fusing the bones, which of course then you don't have the mobility, but it takes care of the pain. May also do a laser surgery where we vaporize part of that disc. We may also treat with NSAIDs. Just know with those NSAIDs, like acetaminophen, ibuprofen, ketorolac, naproxen, those can be really upsetting to the GI system, so make sure the person's taking that on a full stomach. Also be aware of the side effects, like ototoxicity. So if they're complaining of like ringing in their ears, which is called tinnitus, then it could be a sign that they're becoming toxic. Because a lot of times people will take more than they need to because they think it's going to provide more relief, but really it's causing a lot of damage. You also want to check their liver functions, renal functions. If they're taking too much, it's going to start causing damage to that. If it's really causing a lot of GI upset, we may also put them on a proton pump inhibitor, like esomeprazole or pantoprazole. So, just need to make sure that we're asking those questions. They may also take medications for neuropathic pain, like gabapentin is a real common one that we'll see. Maybe some antispasmodics, spasmodics. Opioids are something that we try to avoid nowadays just because of that huge risk of addiction. So we'll try to find other things, other pain management before we move to opioids. We may do opioid receptor agonists like tramadol, and again, those corticosteroids. Just know corticosteroids have a lot of harmful side effects over time, so we try to use them sparingly. They can cause a lot of organ damage, and they also cause a lot of GI upset. So again, we may have to give them pantoprazole or esomeprazole or omeprazole if we're giving that. Complications of these back problems could include cauda equina syndrome, which is when these nerves become compressed between the vertebrae. That can lead to immobility and incontinence. You may have a cerebrospinal fluid leak, fat embolism, nerve root pain, or something called failed back surgery, and that's literally just what it says. It's very common for these back surgeries just not to work at all. So scoliosis is our last little exemplar that we're going over, and that is a curvature of the spine. So it could be scoliosis, which looks like an S, could be kyphosis, which my husband calls nerd neck, and that we see that now sometimes in kids and in young adults because they're always looking down at their phones or their devices. Or this lordosis, which is a sway back. So this could be idiopathic, meaning we don't know why this occurs. It could be congenital, meaning that you were born with it. Could be paralytic, where through paralysis over time the muscles become weakened around the spine and they cause a curvature. Could be myopathic, which is a result of muscular dystrophy or polio maybe. Or secondary, which could be a result of any kind of spinal condition like degenerative disc disease or osteoporosis. So we diagnose this through the clinical manifestations. So we look at the curvature of the spine and how severe it is. You might remember this from like grade school. They did this test on you where you lean forward and then they look at the curvature of the spine. So obviously this is pretty severe, and we base it on that angle between 15 degrees and higher. Treatment would include physical therapy. Some people may need to wear a brace on their back. If there's pain involved, we may prescribe analgesics. And then the most severe cases would have to be corrected surgically. So just make sure that you are reviewing all of these things. Come to class with questions. Do your readings, please. And I'll see you soon.